my talk today is on post-op care for brain tumor patients and some neuro-oncology as well. I am not a neuro-oncologist, but I've been taking care of brain tumor patients for about the last 10 years. I started my career at Columbia University and helped develop the Brain Tumor Center there, and just recently moved back over to the West Coast, my home state, this last year. So the incidence of brain tumors and the prevalence in the United States, there's 16,000 new cases every year, 13,000 deaths, and it's 2.4% of all cancer-related deaths. And among these, 60% are malignant gliomas. These numbers are interesting to me because if you look at the prevalence, it's very low considering breast cancer and lung cancer, and funding for those populations is huge. We have such a small percentage of cases that we don't get the funding that we should deserve. And there's not enough known to treat our patients. So getting that out there is really important. For instance, breast cancer patients and breast cancer awareness, we all know what color that is. Pink, right? Do you know what brain tumor is? Gray. It's gray. So it's easy to remember because it's like gray matter, but a lot of people don't recognize that, and it doesn't really pop either as a color. So of primary brain tumors, the percentages of them, the majority are glioblastoma. On this slide you can see it's 41%, and it's written as GBM, glioblastoma multiforme. Fun fact for the day, in 2007 when the WHO redid the nomenclature for brain tumors, they actually took the multiforme away, so it's glioblastoma, but we still use the term GBM or glioblastoma. And the grading system of brain tumors is different than staging of a cancer from a primary site outside of the brain. If you think of a breast or a lung cancer, when the tumor is closest to the site of the primary, it's a lower grade or a lower stage. And as it moves further away, it's staged higher. If it moves into the brain, typically, then that would be a stage 4 disease. Well, since brain tumors start within the brain, they're not staged, they're graded. So the grading is based on what the tumor looks like under the microscope. How much does it look like normal brain tissue? If it looks mostly like a normal astrocyte or oligodendrocyte, it's going to be more of a grade 1 tumor. As the tumor changes, the mitoses increase, you'll go to a grade 2 or a grade 3 tumor. When there's areas of central necrosis and more vascular proliferation, that's when the tumor is going to become a glioblastoma or a grade 4 tumor. The survival rates for brain tumors, you can see grade 1 and 2, 5 years, grade 3, 3 years. Unfortunately, grade 4 tumors, 12 months. These numbers are changing. I don't specifically tell these numbers to patients when they come in. It's a balance between hope and realism in the clinic all the time, and letting them know that there is a bell curve. Where they fall on that curve, nobody knows. They could be on one side or the other, but right in the middle is, for a GBM, is about 12 months. And who gets the brain tumors? Most commonly, it's for GBMs, it's adults between 55 and 65. And if you think about that age in our life, that's the prime wage earning years of our life. We're making the most money we're ever going to make. So if you think about the social structure at home, whether or not that was the father or the breadwinner, and he was the primary wage winner, and now he has the tumor, how's that going to disrupt the social structure of the household? Are they going to make income? Is the wife going to be able to go back to work? There's a lot of social issues here with brain tumor patients, and I'm really passionate about that. You'll notice that in my talk as well. So making decisions for our brain tumor patients has a lot to do with how they're doing clinically. Are they a healthy person? Do they have a lot of comorbidities that are going to affect our decisions whether or not they need resection right away? Should we figure out what's going on with them medically before we take them right to the OR? Is this a primary brain tumor? Is this a metastatic lesion? Do they have a history of a primary somewhere else? And imaging can help us with that, but it's not the overall definitive answer. You always need tissue. So we'll look at some imaging in a little bit. We want to start our patients with a lesion in the brain that we want to make sure that they're protected from seizure. So we typically use Keppra here at UC Davis, and they're going to be on high doses of steroids with Decadron, and then we need to protect their gut from gastric ulcer, so some kind of PPI, Pepcid, Prilosec. And then if it's a non-primary brain tumor, then we're going to work their body up, their CAT scan of chest, abdomen, and pelvis, and then just pre-op labs. So the first step, if you think someone has a brain tumor, those things can mimic a stroke. So we're going to get a CT right away, make sure there's no blood there, they're not having a stroke, and then like Christy said in the neuroimaging talk, the best imaging for all brain tumors is an MRI with contrast. And we have benign tumors as well, so meningiomas, acoustic neuromas, or schwannomas, and you can base your differential diagnoses for these tumors on imaging. But like I had said before, you really need a piece of tissue under the microscope to know definitively what their diagnosis is. So this is an image from Christy before. You can see the dumbbell shape, and we all know what this is, right? Yep, an acoustic schwannoma. At the bottom of the screen, these are typically treated with gamma knife radiosurgery or stereotactic surgery. A patient will come in the morning of, and they're going to get a head frame placed. You can see he's putting the head frame on. From the head frame, you're going to go to a CT scanner. They're going to image the lesion and map out where the radiation is going to go. Then they finally get the radiation in one dose. And then the head frame's removed and they're sent home the same day. Fractionated radiation I'll talk about a little bit later. That's little bits, doses of radiation given over a series of days to weeks. So schwannomas, like I said, radiosurgery mostly is how we treat them now. If they're a very large tumor, we can't use radiosurgery. They're going to need an open craniotomy. And typically they present with unilateral hearing loss. So they're not going to hear on that one side. They may have trigeminal neuralgia if the tumor's large and pushing on that fifth cranial nerve. This tumor is, you can see it's starting at the top of the brain around the meninges. And it's homogeneously enhancing, and you saw it before, so you probably know what it is, a meningioma. So this person needs a craniotomy. After a craniotomy and you have a meningioma, they also can use gamma knife radiosurgery for whatever is left behind, any residual disease. Meningiomas are graded into 3 grades. Grade 1, which is more benign, grade 2 is atypical, and then there are malignant meningiomas. Even though these tumors are thought to be benign, you have to also look at where they're located and if they are resectable. So it's a philosophical thought of whether or not it's actually benign if it's in a location that you can't even resect. What does that mean for that person, and how are you going to treat them in the long run if you can't get to it and it's still growing? The area of central necrosis you can see on the CAT scan versus the MRI. The CAT scan's below, the MRI is above. And when you see that tumor with that hole in the middle of it, it's just dead tissue, automatically we think it's a GBM, and this person needs a craniotomy. So for GBMs, it is a brain cancer. It's a grade 4 tumor. As I said before, the estimated survival time is about 12 months. If you don't get treatment, you may only live 28 days to 3 months. And typically you're treated with chemotherapy and radiation concurrently. And I'll go into the dosing of that in a little bit. And this was what I touched on before with a meningioma or a benign tumor. They can all be slow growing but have malignant potential. If that location is located, that is in an eloquent part of the brain, and you cannot resect it, then it can prove lethal for the patient. So our goals of treatment, cure for the majority of our patients, that is our goal. Whether or not we can achieve that is for grade 3 or 4 tumors is questionable. Their tumor will recur, but we can't predict that. We don't have a crystal ball. But we try to do the best we can and promote a good quality of life for them for as long as we possibly can. And limitations of our surgeries, where the tumor is located, and if someone keeps having a recurrent tumor that we keep going back and resecting over and over again, they're at risk for infection, poor healing, and CSF leaks. And when we give chemotherapy, some of our anti-epileptic drugs can interfere with our chemotherapy, like Dilantin, carbamazepine. Steroids can actually protect the brain and not allow the chemotherapy to actually create cell death. So when patients are receiving radiation with temozolomide or Timidar, we want them on the lowest possible dose of Decadron possible. Some patients can make it through radiation with a little bit of steroid or none at all, but the majority of my patients need a touch of steroid to make it through it. The radiation is very irritating to the brain and can cause cerebral edema as it destroys that tissue, and then you need that Decadron to pull that swelling down. So chemotherapeutics with glioblastoma, like I had said before, we start them. First line treatment is radiation with Timidar or temozolomide. They're given radiation for 6 weeks. It's Monday through Friday. And then Timidar is given daily for 42 days straight. They take it on the weekends. It's an oral chemotherapeutic agent that you take at home. They're pills. And I typically have my patient take it at night before bed on an empty stomach. And hopefully that'll help them sleep through any nausea or side effects they may experience. Other neuro-oncologists like them to take it an hour or two before radiation. I don't know which way is the best way. I don't know if it's proven. I think it's just how people practice. Anaplastic astros and oligodendrogliomas are grade 3 tumors, but they're also treated like a GBM. So the majority of them will undergo radiation and chemotherapy with Timidar as well, the same way that we treat our GBM. However, an anaplastic oligodendroglioma, as well as all of our brain tumors now, we're molecularly profiling the tumors. So for an oligodendroglioma, there's some genes that if they're deleted, called 1p19q, they will have a better sensitivity to chemotherapy and radiation therapy. And also that indicates that they may have a better outcome with different chemotherapeutics than Timidar. For instance, there is a regimen called PCV, procarbazine and cysteine vincristine, and that's given after radiation therapy, but it's up to the oncologist to determine. Some second-line therapies that we use now for GBMs that have recently been approved is Avastin. Most people are familiar with that for a lot of different cancer primaries like breast cancer, lung, and colon cancer. It has been approved for only in the recurrent setting of a GBM, not upfront yet. So where the timing is for Avastin to be given is not actually known when it's best, if it should be given right up front with your radiation or your Timidar or later on. No one really knows the answer to that yet. And it's also thought that it might mask tumor growth. It can pull swelling out of the brain and the imaging can look really pretty on MRI, but is the tumor just being, the contrast just not lighting up? It's very tricky, and that's why you need a neuro-oncologist. Right now, for clinical trials for our brain tumor patients, immunotherapies are huge. So, like I had said before with the molecular profiling of tumors, in the future I think that we're gonna see that our tumors they're gonna be treated based on what receptors and deletions are on your specific tumor type. It's not going to be a standard Timidar radiation for everyone. It may be that plus a biologic agent plus a vaccine. It's changing rapidly. Some complications. Post-operatively, when we're on steroids, we can have high blood sugar, so we want to monitor our sugar. And because of the steroids, you're not sleeping, and you're waking up in the middle of the night to urinate, and you can have mania, and you're talking really fast. Everyone has seen these patients in the hospital, And the only thing we can do for them is to get them down at the lowest dose they can handle, those steroids. We're going to watch that wound for breakdown, especially if they're going to start undergoing radiation. That can cause wound breakdown as well. So we see them back in the office frequently to do wound checks. And then DVTs, when to anticoagulate them is a question with a brain tumor. We typically wait for a little bit. We don't want them to bleed into their tumor bed. And then in the hospital, UTIs from the catheter. Seizures, for seizure prophylaxis, we use Keppra for most of our patients here at UC Davis. Seizures could be just based on the location of the brain or the location of the tumor within the brain. And in this patient, the frontal lobe. You have a talk on seizures later, so I'll let her continue on with seizures. This is a case study. It's an 82-year-old man. You can see on imaging, when you look at an MRI, the right side is actually the left and left is the right. So he has a left frontal meningioma and he is going to undergo a craniotomy. So this is the case. He goes into the OR. They mark out on his scalp where they're going to make their incisions. This is the bone. So when you're doing a craniotomy, you drill through the bone and then you're going to connect those holes to make the bone flap, the window to remove the tumor, and you can see the scalp has been pulled back. This is the bone being removed. It's going to be replaced later with little titanium plates. And there's the tumor right at I can't get the mouse to work up here to show you, but you can see right where his instrument is, that the tumor's right below that. And then the tumor's removed. And that is what you would call a gross total resection. There is no tumor left behind there. So then they're going to close all that up. They're going to close the dura. They're going to put the bone back and close the scalp. So he had an unremarkable pre-op exam. He had diabetes and hypertension. Post-operatively, he was stable for 3 days. He develops uncontrollable headaches. When our patients have had a craniotomy and their headaches are not getting better, they're getting worse, what should we do? CT of the head, right? We get a CT and lots of blood. So he needs to go back to have that hematoma evacuated. So we want to always control or get a CT right away for any uncontrollable headaches post-operatively. Make sure that they're on steroids. Monitor that blood glucose. Keep them on PPI to protect their gut, and seizure prophylaxis. So we're going to keep that craniotomy site clean and dry. Get them up and out of bed because we're not really giving them any heparin. We don't want them to bleed. Incentive spirometry while they're awake, and a lot of social support for the family. I love this slide. This was a patient of mine. She did a graphic for me. She has a grade 3 tumor. She's my age. She's in her mid-30s. And she was diagnosed in about 2008. And you can see how her thought process changed over time. In 2007, she was working hard, she was excited about life, new boyfriend, things were going great. In 2008, she was diagnosed with this brain tumor. And all her thought structure changed from life and the future to cancer and money. Money is a huge problem with our patients because they can't work. Radiation therapy, when they're prescribed it, is 6 weeks. You can't work during that time, it's every single day. And then once you finish radiation, you get a month off and a break, and then they restart the Timidar, the temozolomide for 5 days every 28 days. So it continues on. It's a little bit different because now the drug is not so mysterious. They're familiar with it. They took it during their radiation treatment. And it becomes a little bit more manageable and patients can go back to work. So she had finished her radiation and she had restarted her Timidar. And then things changed a little bit and got a little bit better. And you can see in 2012, life took over some more. She got some of that back. She went back to work. She had a new job by that time. And cancer is in the back of her mind. Our patients have to get MRIs about every 2 to 3 months. So Some of them are just living month to month or MRI to MRI. So you get the MRI, you get the result hopefully the same day. That helps a lot for their anxiety level. And then you live your life for the next 3 months trying not to think about it, but then that MRI pops up again and you have to come back and then go over this over and over and over. So what is most interesting to me is who's involved in their life. When I see them, I want to know, do they have a pet is really important to me. That can provide a lot of happiness within the home. Their friends, who comes to their appointments with them. Is it a young guy that's a bachelor that doesn't have a wife yet but may have a girlfriend, and I want the girlfriend to stay with the boy through the treatment so she can help care for him, so making sure she's well informed. Are they involved in different groups? Do we have a social worker available for them? We have a brain tumor support group here at UC Davis that I run with another social worker. The American Brain Tumor Association has a lot of information for brain tumor patients. They actually post all their support groups within the areas, and their 1-800 number can provide like a hotline, instant relief for them. They can just talk to someone over the phone. Previously, I had done a symptom management program at Columbia. We created this because we found that our patients needed more than a 15-minute, 30-minute visit to review an MRI and to go over what's next in terms of their treatment. They needed an hour, maybe once every few months. And that would be with myself, another nurse practitioner, and a social worker. And during that visit, we could really go over what's going on at home, what's the family situation like, are their seizures being managed well? Do they need to come up or down on their steroid? Because it's always in flux, up and down, up and down, up and down. It's a good opportunity for us to talk about advanced directives, hospice care, palliation, what they want when they're exhausted of treatment and they don't want to do this anymore. Because that's an ongoing conversation we need to have with our patients, and they're not going to have it with you unless you have a relationship with them. And they know what's going on. It's just they need someone to talk to about it. So being there for them is really important. All right, thank you.